Okay, so let's start. Today we are going to start the important topic, that is the cell death. And in the cell death, we will discuss the two important methods through which cell is going to be died. First one is the apoptosis and second one is the necrosis. So we'll discuss both the topics today. So first of all, before directly starting this topic, you guys have to understand the basic principles of cell death. First of all, let's suppose if they ask question from you, what is the morphological hallmark of cell death? Like if they ask from you this, so what is the answer of this question? The morphological hallmark of cell death, basically it is the loss of nucleus. So this is the morphological hallmark. Like if you see this, the loss of nucleus, then you say like the cell is going to be died or cell is died. So what is the mechanism through which the loss of nucleus is going to be occurred? There are three mechanisms through which nucleus is going to be lost. So first one, there is a mechanism which is called pycnosis. So what is the meaning of pycnosis? When the nucleus undergo condensation, it is called pycnosis, and through this, the nucleus is going to be lost. And the second is through the fragmentation. If the nucleus is going to be lost through fragmentation, it is called karyohexis. So what is the meaning of karyohexis? Basically, it is a process in which nucleus undergo fragmentation. And on the third point, we have to understand if the nucleus is going to be dissolved, it is called karyolysis. Yeah, so what is the meaning of karyolysis? Basically, it is a process in which nucleus is trying to dissolve itself, and after dissolving, the nucleus will be lost. So these are the three mechanisms through which the loss of nucleus is going to be occur, and this is the morphological hallmark of the, you can say, cell death. And then we have to understand the how many mechanisms of cell death are. In cell death are basically two mechanisms. So first one is the necrosis and the second one is the apoptosis. Today, first we will discuss the necrosis and after that we will discuss the apoptosis. So before again starting this topic directly, we have to understand the basic terms. So let's suppose I am taking the example of one cell. Let's suppose this is an example of one cell, and as we already discussed that whenever there is some kind of stress on this cell will undergo growth adaptation. And growth adaptation means if the cell is going to increase its size, it is called left ventricular hypertrophy. If cell is going to increase the number of cell, it is called hyperplasia. And it is mainly because of stress. And you know, if you remove the stress, the cell will undergo its normal structure. But what happened if you are not, you can say, removing the stress? And what happened to this cell? So if you are putting a stress on the cell and you are not removing this stress, this cell will become injured. And you know that cell injury is of two types. One is reversible and second one is irreversible. I am going to again repeat. First of all, we try to understand this basic concept. Whenever we are putting a stress on the cell, that this stress is going to change the shape or structure of a cell, that is growth adaptation. And if you are not removing the stress in future, or if your stress is persistent, continuous, or beyond the limit of the cell, your cell become injured. And injured cell is, you can say, the injury of cell is of two types. One is reversible and irreversible. The reversible mean if you remove the stress, the cell will come to its normal shape. But irreversible cell injury mean even if you remove the stress, the cell is not going to be coming back to its normal position. So irreversible cell is going to be died. So you can say necrosis, basically it is an irreversible cell injury. And please always keep in mind that kind of injury is always exogenous. What is the meaning of exogenous? Like necrosis is always pathological. You cannot say like necrosis is physiological. Like it is not the normal physiological thing that is going to happen in our body. There is some kind of exogenous injury. and that exogenous injury will lead to plasma membrane damage. So let's suppose this is the cell. Again, let's suppose this is the cell, and if there is any kind of trauma or is there any kind of injury from outside, and that injury will lead to irreversible cell injury. And after the irreversible cell injury, now cell is going to be died. And what will happen if the cell is going to be died? There is the damage of this plasma membrane. And when the plasma membrane get damaged, what will happen? We know that inside the cell there are certain kind of components, there are certain kind of enzymes. So when the plasma membrane get damaged, these intracellular components will come from inside to the outside. So it's mean when the plasma membrane get damaged, these intracellular components will start leaking. They will come outside to the surrounding environment. And what will happen next? Then the cell will undergo enzymatic degradation and protein denaturation. So you have to keep in mind, first of all, necrosis is always pathological. Necrosis will occur when the cell is unable to handle the stress, and the stress is so, you can say, so strong that cell cannot undergo growth adaptation, or cell is, you can say, has any ability to face this stress, then cell will undergo injury. An irreversible type of injury is called necrosis. You can simply define it also. Necrosis, what is necrosis? It is a death of large group of cells, which is always irreversible. Then you have to keep in mind necrosis is always pathological. Then, as I told, there is some kind of stress, there is some kind of injury from outside. That injury will lead to the plasma membrane damage. And when the plasma membrane get damaged, there are intracellular enzymes. These enzymes will come outside, and these enzymes will lead to the degradation of the cell and protein maturation of the cell. And after the intracellular components get outside, then you can also see, let's suppose if there is some kind of enzyme that is inside the cell, and when this enzyme will come outside to the surrounding tissue, then the surrounding tissue will also become inflamed. So that can lead to local inflammatory reaction. And this is the important difference. Like apoptosis is also a kind of death, but apoptosis we will study later on. It will not lead to the surrounding tissue inflammation, but necrosis can lead to surrounding tissue inflammation. So here I want to give you guys one important table difference which you guys can remember, which you can especially you guys can remember as a difference between the apoptosis and necrosis. They can also ask you from this in exam, what is the important difference between necrosis and apoptosis. So here I am going to uh, mention some important differences between the apoptosis and necrosis. We will study this topic in the evening class, but let's take a difference here. First of all, you have to keep in mind necrosis is always pathological. This is a first major difference, always pathological. But apoptosis is always physiological or pathological. It can be physiological, it can be pathological. Then necrosis always affect the adjacent cells or adjacent tissue. Like I mentioned here, when the plasma membrane get damaged, the intracellular enzymes will come outside, and they will lead to degradation and protein denaturation, which will lead to surrounding inflammatory reaction. But in apoptosis, there is no adjacent cell inflammation. Apoptosis always affect the single cell, but necrosis affect the multiple cell. Then you have to keep in mind, in the necrosis, when the cell is affected, its size is increased. In necrosis, affected cell size increase, but in apoptosis it will shrink. Then you have to keep in mind the necrosis is a passive process. Passive process means you don't have to give any kind of energy. You don't need any energy. It is a passive process. But apoptosis is an active process. You need energy. You have to keep in mind. Then you have to also keep in mind when the necrosis occur, it can lead to inflammatory condition. But in apoptosis, no, there is no any kind of inflammation. So these are the major difference. Then very important point, in the necrosis, plasma membrane get damaged, but in the apoptosis, plasma membrane remain intact. So it's mean when the plasma membrane remain intact, then there are no degradation of enzyme. You can say there is no degradation of enzymatic proteins and denaturation of the protein will occur because the intracellular components are not going to be leaked because the plasma membrane is intact. So this is the major basic difference between the necrosis and apoptosis. Now let's discuss the different types of necrosis, and I will explain everything according to your exam. Please try to remember these things or try to remember only the information which is explaining to you because your USMLE exam you don't need to memorize everything from the Roban. You don't need to memorize everything from the Pathoma. You just have to make your concept clear. Let's suppose if I say plasma membrane damage, so you guys have to understand it is a type of necrosis in which plasma membrane get damaged, and after the plasma membrane damage, what will happen? Intracellular components will become leaked, and when they leak, they come outside, they start degrading the things, and protein become denatured, and that will lead to local inflammatory reaction. So just try to memorize everything step by step. First try to clear your concept, then after that try to memorize the things. Now let's talk one by one. First of all, we will discuss the type of necrosis is coagulative necrosis. So I will highlight the important points which you guys have to remember. For example, first of all, you guys have to remember in the coagulative necrosis, first of all, they will ask question from you like what are the examples of organ which can undergo this coagulative necrosis. You have to keep in mind in our body, except the brain, everything when it get ischemia or infection, it will go undergo coagulative necrosis. So it's mean ischemia and infection in most of the tissues of our body except the brain. In brain, never ever pick the coagulative necrosis. In brain, there is no coagulative necrosis. Please keep in mind. Then after that, you have to keep in mind why this coagulative necrosis will happen. What is the reason? What is the reason of coagulative necrosis? It is mainly because of ischemia or infection. When there is ischemia or infection, then the tissue will become injured, and then the tissue will become injured. It lead to the denature enzymes that will lead to the proteolysis block. So I will explain again. First of all, try to keep in mind coagulative necrosis. It is a type of example. It is a type of necrosis which can be seen in almost every tissue except brain. Then what happens in coagulative necrosis? You have to keep in mind when there is ischemia or infection that will lead to denaturation of the enzymes. And if your enzymes are denatured, you cannot break down the protein. So it's mean if you cannot break down the protein, then your necrotic tissue, cell shape, and organ structure are preserved. So this is very, very important MCQs. They can ask from you how in coagulative necrosis the cell architecture is going to be preserved. It is the reason. It is a reason because in the coagulative necrosis, the enzymes are going to be denatured. When the enzymes are going to be denatured, then the proteolysis is blocked. And when the proteolysis is blocked, it's mean cell architecture or cell structure, cell shape is going to be preserved. Please keep in mind. But the nuclear will disappear because I already told you what is a hallmark of necrosis or what is a hallmark of cell death. It is the loss of nucleus. So nucleus has to disappear, but in coagulative necrosis, the cell architecture is preserved. How it preserved? Because the proteolysis is blocked. Why the proteolysis is blocked? Because the enzymes are not uh, enzymes are going to be denatured, and when the enzyme become denatured, it is unable to perform the proteolysis. It is unable to break down the protein. You have to keep in mind. Then in the coagulative necrosis, when you see the tissue under the microscope, you will see the cytoplasmic binding of eosinophilic staining is increased. So eosinophil mean it is going to be it is going to look red or pink in color under the microscope or under the histology. So eosinophilia simply mean the tissue become more red and pink. And you also have to get familiar with another term, that is basophilia. Basophilia mean it is going to be more blue, and if it is going to be more red or pink, it is called eosinophilia. So these are the important parts. So let's take a quick review. What are the questions they can ask from you this type of necrosis? First of all, they can ask from you in which parts of the body, in which body part coagulative necrosis is not going to be happen, that is brain. Second, they will ask question from you, in coagulative necrosis we see there is a preservation of cell structure or cell architecture. What is the reason? So the reason is basically enzymes are become denatured, and when the enzyme become denatured, you are unable to break down the protein. So this is about the coagulative necrosis. Then you have to discuss about the second type of necrosis, that is liquefactive necrosis. We have to compare the coagulative and liquefactive, because if you compare the things, then it will become very easy. First of all, what are the examples of liquefactive necrosis? You can see it in bacterial abscesses. You can get in CNS infection. So it's mean if the person has bacterial infection, after the infection, it will if the person has abscess, then in the abscess you can see the liquefactive necrosis. Then second, if a person has CNS infection. So these are the two important causes in which you get the liquefactive necrosis. It's mean it can be seen in bacterial abscess or CNS infection. Now, why this liquefactive necrosis is going to happen? So in the liquefactive necrosis, basically the neutrophil will release the different kind of enzymes. That enzymes will go and they digest the tissue, they digest the proteins. So it's mean in the liquefactive necrosis, the enzymes are not going to be denatured. Enzymes are released and they will go and damage the tissue. And when the tissue get damaged, their cell structure is not preserved. In the liquefactive necrosis, you will see there is no preservation of cell structure or cell shape. You have to keep this in mind. This is an important difference. So, but let's once again I repeat this: liquefactive necrosis. You have to keep in mind the necrotic tissue become liquefied. How the necrotic tissue become liquefied? It is because of neutrophil. The neutrophil will release the enzymes, and these enzymes will go and digest the tissue. And when they digest the tissue, the cell size, shape, structure is not going to be preserved. You have to keep in mind. Then you have to take an example like in the brain, in the brain infection, in the bacterial abscesses, you will see the liquefactive necrosis. You have to keep this in mind. And if they ask question from you in the brain infection, how you guys how this is going to be happen, how the liquefactive necrosis will occur, then you have to keep in mind basically these are the proteolytic enzymes. The proteolytic enzymes are released from the microglial cell, and those proteolytic enzymes will digest the tissue. So this is about the central nervous system. And if they ask about the abscess, like in abscess, how you get the liquefactive necrosis, how your tissue become liquefied. So you can say when the person get abscess, in the abscess there are proteolytic enzymes which are released from the neutrophil, and these enzymes will liquefy the tissue. In the brain infection, your microglial cell will release the enzyme, but in the abscess, your neutrophil will release the enzymes which will liquefy the tissue. So if you see under the histology, you will see like in the early case of liquefaction, you will get the cellular debris and macrophages. This is the hallmark of early liquefactive necrosis. You will get the cellular debris and macrophages. But what is the late? In the late case, you will see the cystic spaces and cavitation. We will see after completing this page on the diagram. Diagram B, basically it is an example of liquefactive necrosis in the brain. In the brain, if the liquefactive necrosis get late, then you will see there are cystic spaces, there are cavitations. You have to keep in mind. And then the neutrophil and the cell debris seen with bacterial infection. As I already mentioned, if you have the bacterial infection, if you have the bacterial abscess, you will see their neutrophils. And the neutrophils are the main players which will help the tissue to become liquefied. And neutrophil will release the enzymes. Those enzymes will go and digest the tissue. So that's all about the liquefactive necrosis. Now let's take an example of caseous necrosis. So first of all, how they can ask question from you from the caseous necrosis. So first question, they can ask from you, please give the examples or pick the answer in which you can see the caseous necrosis. So caseous necrosis is going to be seen in TB. It is going to be seen in systemic fungal infection like histoplasmosis, capsulatum. Then it can also see nocardia. So these are the infections in which you get the caseous necrosis. And what happened in caseous necrosis, you have to keep in mind there is formation of soft and friable necrotic tissue. and the appearance of this tissue is coated cheese-like. Please try to remember these terms. First of all, what happened in caseous necrosis? The tissue becomes soft and friable. The tissue becomes soft and friable, and the tissue that becomes soft and friable, it looks like cheese type, cheesy cottage appearance. You have to keep in mind. And always remember one thing: caseous necrosis is a combination of coagulative and liquefactive necrosis. They can ask you from this in example, like they can ask from you in exam. Caseous necrosis is a combination of what two type of necrosis? It is a combination of coagulative and liquefactive necrosis. You have to keep in mind. Then also, as I already told you guys, in the TB, we know that in the tuberculosis infection, we have the granulomas. We have the granulomas, and granuloma is found with the help of macrophages. So basically, these macrophages will wall off the infecting microorganism, and that will lead to granular debris. So if they can, if they ask from you in exam, like how the granuloma is going to be formed. So it is going to be formed with the help of macrophages. Let's suppose this is the bacteria, and this bacteria is walled off, surrounded by the macrophages, and that macrophage is then going to form the granular debris. This is called walled off. You are covering the bacteria. Then if you are going to see this caseous necrosis under the histology, you will see the fragmented cell and debris which are surrounded by lymphocyte and macrophages, which is called granuloma. So in its mean in the center you will get the bacteria like a Mycobacterium tuberculum, and on the side of this bacteria you will get the lymphocyte, you will get the macrophages, and this complete structure is called granuloma. And if you see this granuloma under the histology, it looks like cheese. It looks like cottage cheese like appearance. So they can ask from you, like if they give you a histology, in which kind of necrosis you will see the cottage cheese appearance, then it is seen in the caseous necrosis. Then after that, we have to read about the fat necrosis. First of all, fat necrosis seen in two main categories. One is enzymatic and second one is non-enzymatic. First of all, enzymatic mean if the person get the pancreatitis, when the person get the pancreatitis, there is the accumulation of calcium on the surrounding tissue of pancreas. Let's suppose you can say this is the pancreas, and this is the surrounding tissue of pancreas or surrounding fat of pancreas, which is called peripancreatic fat. If the calcium become, if the calcium get deposited on this tissue, this is called sponification of peripancreatic fat, and it is a example of enzymatic type. And what is an example of non-enzymatic? Basically, it is only seen after the trauma. Like if the female get trauma to breast, and after the trauma, you see there is calcification of breast, and it is non-enzymatic. So always keep this in mind. Like fat necrosis. Fat necrosis basically, first of all, try to remember it is a type of necrosis in which adipose tissue get the chalky white appearance. When the calcium is going to deposit on the tissue, it will become white. It will become chalky white because of deposition of calcium. Then you have to keep in mind it is a, like you can say, fat necrosis is usually seen in traumatic and non-traumatic causes. And non-traumatic causes, I explained to you, it is the pancreatitis. And traumatic cause is breast trauma. So always please keep this in mind. And if they can ask from you this in exam also, like if person get pancreatitis, how the calcium is going to be deposited. So please always keep in mind when the person has pancreatitis, in case of pancreatitis, we know that there are different kind of enzyme are going to be released like lipase. So when the person get pancreatitis, this lipase enzyme will join the calcium, and with the help of process, that process is called sponification. Sponification is a process in which lipase is going to be joined to calcium. And what is an example of non-enzymatic? Non-enzymatic mean the after the trauma, the calcium is going to be directly deposited on the tissue without any help of enzyme. That is called non-enzymatic. So always please keep this in mind. Then why a person get fat necrosis? It is because, as I already explained, when the pancreas get damaged, it releases the lipase. This enzyme, you know, this is an enzyme, and that enzyme will break down the triglyceride into the fatty acids. And when the fatty acids are formed, they bind the calcium. This is called sponification, and you see that this is mainly because of this lipase. Lipase is an enzyme, So that's why it is called enzymatic. And after, as I mentioned, the second example, non-enzymatic in the case of breast trauma. In the case of breast trauma, there is now not any kind of lipase is going to release. It is simply the calcium is going to be deposited on that tissue. That is called non-enzymatic. So always, please remember these things. If they ask from you in exam, like how the pancreatitis lead to sponification, how the pancreatitis will lead to the calcium deposition. You just have to memorize. You just have to understand when the pancreas get damaged, the release of lipase, that lipase will break down the triglyceride into fatty acid. This fatty acid will go and bind the calcium, and this is called sponification. And when the calcium will bind, it looks like chalky white appearance. Then, what is the histological pattern? You will see outlines of dead fat cells without peripheral nuclei. You will see the sponification of fat combined with calcium. And on the hematoxylin and eosin stain, you will see it looks like dark blue. So these are the histological pattern which you guys have to keep in mind. So here I want to add two more things. Please try to note these things on your first aid. So first of all, I have one question from you. You guys can tell me what is the difference between dystrophic calcification and metastatic calcification, because they can ask from you in exam, because sponification is an example of dystrophic calcification. So if they ask from you in exam, if they they are going to ask question from you, sponification is an example of what kind of calcification? It is a dystrophic calcification. Basically, dystrophic calcification in which the calcium deposit on the dead tissue. In dystrophic calcification, the necrotic tissue act as, you can say, the favorite place for calcium in the setting of normal calcium level and phosphate. So if you can, I will again repeat, person has normal calcium and phosphate level, but when the tissue become injured, that tissue is going to catch the calcium in case of normal calcium and phosphate level. This is an example of dystrophic calcification. But what happened in metastatic calcification? In metastatic calcification, it is opposite to dystrophic calcification. And it occurs when serum calcium or phosphate level is high. So when the serum calcium level is high, it is going to deposit it on the normal tissue. This is called metastatic calcification. In dystrophic calcification, please always remember, calcium serum level is normal, but tissue is abnormal. In dystrophic calcification, serum calcium level is normal, but tissue is abnormal. But in metastatic calcification, serum calcium is high, but the tissue is normal. So this is a difference between dystrophic and metastatic calcification. You guys have to note all these things on your exam, on your book. And if they ask what is an example of metastatic calcification, you can say the hyperparathyroidism. In hyperparathyroidism, if you get the cancer in case of hyperparathyroidism like adenoma, hyperplasia, your blood level of calcium is increased. So this is an example of fibrinoid necrosis. So just let me move a little bit. Okay. So now we will discuss the fibrinoid necrosis. So first of all, you guys have to keep one thing in mind. Fibrinoid necrosis, it is a type of necrosis in which your blood vessel wall become necrotic. Basically, it is a necrotic damage to blood vessel wall. And what happened in this, when your blood vessel wall get damaged, there is leakage of proteins, including fibrin, into the vessel wall. That's why it is called fibrinoid. Fibrin is basically a protein, and when your blood vessel become injured, there is a leakage of this protein into the vessel wall. And when this protein get deposited in the vessel wall, it lead to the bright pink appearance when you see under the microscope. And they can ask from you in exam, like, can you give the example of fibrinoid necrosis? Basically, there are two main, you can say, causes in which you can see the fibrinoid necrosis. One is the aminovascular reaction like polyarteritis nodosa. It is the immunological problem. And second is the non-immunological problem like hypertension or preeclampsia. You guys have studied in pathology, a general systemic pathology, like hypertension is not due to immune system. Hypertension is non-immune disease, a non-immune stimulatory disease. So, but fibrinoid necrosis can be seen in both. It can be seen in aminovascular diseases. It can be seen in non-aminovascular diseases. What is an example of aminovascular diseases? Polyarteritis nodosa. What is an example of non-aminovascular disease? Hypertension and preeclampsia. And what happen in immune complex diseases, in immunovascular diseases, basically there is deposition of immune complex, and that we will study in the, you can see immunology. They can ask from you in fibrinoid necrosis, what are the deposits that are going to be deposited in different kind of tissues. Those are immune complex deposit, and it is a type of hypersensitivity reaction you guys have to keep in mind. And second, as I already mentioned, in fibrinoid necrosis, your blood vessel get damaged, and when your blood vessel get damaged, there is a leakage of plasma protein in your vessel wall. And when the vessel wall get this protein, it looks like eosinophilic, because the fibrin is going to be deposited on the vessel wall. So I will again explain with an example. Let's suppose this is the blood vessel, and this is the vessel wall. So this is the vessel wall, and this is the lumen. So when this blood vessel wall will become damaged, so when this vessel wall become damaged, there is a protein which will go from lumen toward this vessel wall. So when the protein get deposited in this vessel wall, it looks eosinophilic under the microscope. Why? Because of this protein, because of this fibrin. So fibrin basically it is a proteinaceous material. When it get deposited in the vessel wall, it looks eosinophilic under the histological or microscope. So that is about the fibrinoid necrosis. The important points are, first of all, fibrinoid necrosis, basically it is a necrotic damage of the blood vessel wall. When the blood vessel wall become damaged, there is a leakage of protein including fibrin in the vessel wall. And when this protein get deposited in the vessel wall, it looks eosinophilic, pink, you can say a red, under the histological pattern. And they can ask from you in exam, like give an example or pick the example of fibrinoid necrosis. You can say hypertension, preeclampsia, and if they ask about immunological cause, you can pick the polyarteritis nodosa. Then if we talk about the last type of necrosis, that is gangrenous. So again, first of all, we have to understand some basic point. So first of all, the gangrenous is seen in distal extremity and GIT tract after chronic ischemia. So what is an example? Like you have to understand this with the help of example. Like under which condition you can get like chronic ischemia. You have to understand like atherosclerosis. You have to understand like in case of diabetes, if the person is chronically diabetic, so you see that in case of diabetic patient, atherosclerotic is going to be more. That will lead to distal extremity or intestinal ischemia. So this is usually seen in those parts. So gangrenous necrosis is of two types. One is dry and one is wet. In dry, you will get the ischemia, but in wet, you will get the superinfection. And dry ischemia, basically, it is of coagulative necrosis. And in the wet ischemia, you have to keep in mind, it is basically liquefactive necrosis, which is going to superimpose on coagulative necrosis. Like if they ask from you, what is wet gangrenous necrosis, you will say like person first get the coagulative necrosis, and on the coagulative necrosis, if you like get liquefactive necrosis, it will become wet, because coagulative necrosis, it is a coagulation of proteins. You will get the dry necrosis. And but if on that necrosis you get the, you can say, liquefactive necrosis, it become wet. These are the important points. So let's again highlight the important points in case of gangrenous necrosis. You have to remember, first of all, coagulative necrosis that resemble the dry, you can say dry necrosis or dry gangrene. Then after that, you have to keep in mind, especially the lower limb and the GIT tract are going to show the gangrenous necrosis. And if a dead tissue, already if a dead tissue is because of coagulative necrosis, and if you get the superimposed infection of that dead tissue, that dead tissue will become the liquefied, and the liquefied thing is always wet. So always try to keep in mind, first of all, if a dead tissue, if a death of the tissue is occurred through coagulative necrosis, after the death, if that died tissue get the superimposed infection, it is going to be convert into liquefactive necrosis. So these are the, you can say, the example of gangrenous necrosis. Now here you can see like they give the examples, like diagram. They mention here picture A, picture B, C, D. So let's suppose take the example of this dry gangrene. You can see this is the, this is an example of dry ischemia. Here we will see the diagram of dry ischemia. So you can see here, basically this person has the gangrenous. It is a type of dry ischemia. So it is an example of gangrenous necrosis or dry ischemia. And also, if you can see here, basically here they talk about the fibrinoid necrosis. In the fibrinoid necrosis, let's take the example of diagram E. So in the diagram E, you are going to see here this pinkish material, this one. Basically, it is a fibrin protein. It is a fibrin protein. You can see here this one. This is the fibrin protein that is going to be deposited in the vessel wall. How it is going to be deposited? Because of vessel wall damage. You can see it. Then here you can see the fat necrosis. You can see here the fat necrosis. So this is an example of fat necrosis. Then after that, here you can see the example of caseous. This you can see white cheese-like material. This is caseous necrosis. And if you see here, here are the example of like cystic or cavitatory disease of the brain. It is an example of liquefactive necrosis because liquefactive necrosis is going to be occurred in the brain. And here you can see in the first diagram, they give the example of coagulative. In the coagulative necrosis, I already mentioned, it will become more pink red. You will see more eosinophilia. It is not basophilic, it is eosinophilic. So that is about this diagram. So that is the topic of, you can say today, uh, of necrosis. With time, we are going to increase the topics one by one. So please try to revise all the topics. And in your WhatsApp group, you will get the questions from these topics as we finish. After finishing the first chapter of General Pathology, I will send some important MCQs related question in your WhatsApp group. So you guys can practice those questions. And if any student has any question related to these topics, you guys can ask in the WhatsApp group, or if you guys have any question which you want to share, you guys can also share in the WhatsApp group.
Hello, good evening everyone. Today we are going to start USMLE practice question, the USMLE practice buds, that is related to our previous topics regarding the general pathology and growth adaptations and second cell entry. The first question is, a 32-year-old chef. A 32-year-old chef accidentally slices into the tip of her tongue while her bread trimming streaked with a knife. The laceration extends through the skin into a subcutaneous bud. Skin to subcutaneous, which is the following sequence, is most likely to occur in the subsequent wound healing process. In this MCQ, we have to give the right sequence of wound healing. We all know in the first and step in the wound healing is fibrin plot formation. Okay, suppose you go with these two options, other that are wrong. Well, second step is cerebral infiltrations, then it's alone, then last angiogenesis. How these all the things are going on? Simply the wound healing having the 4 steps: hemostasis, inflammation, proliferation, and maturation. What's the hemostasis? In hemostasis, immediately after the tissue injury involves small vessel constriction, platelet aggregation, and clotting cascade activation that lead to platelet plugging, fibrin clot formation, and cessation of plating. For relatively minor injuries, hemostasis is often accomplished within the minutes, and maximum is from 1 hour to 1 day, but for the minor injury, it's accomplished within the minutes. The fibrin clot that is formed during this phase provides a supporting unit for the wound healing. And second is inflammation. In inflammation, if you really start within the hours of entry during this phase, mast cells degranulate, releasing histamine and other chemical mediators that increase vascular permeability and promote cellular infiltrations like neutrophils and monocytes. And secondly, these neutrophils digest bacteria, necrotic tissues, and foreign debris. The monocytes are transformed into macrophages, which secrete growth factors like transforming growth factor beta, and also there is a vascular endothelial growth factor. This all promote the next phase of healing that is called the proliferation. In proliferation, there is epithelialization, There's fibroplasia, there's an angiogenesis. What is epithelialization in basic keratinocyte proliferation and migration of new epithelial cells form a new superficial epithelium that exceeds a barrier to the bacteria. New epithelium will be formed. And second, fibroplasia, mean new fibrous tissue will be formed. And thirdly, the angiogenesis, mean new blood vessels will be formed. But not last, steadily marching on maturation. In the final phase of the wound eating reserves and the collagen remodeling and the cross-linking, which are primary mechanism by which the tensile strength of the wound increases. In which the formation of type 2 collagen and type 1, and this make a cross-linking of collagen and make the wound stronger and stronger. Now really moving to our next question. Our next question is, a 73-year-old man come to the emergency department with right-sided weakness and difficulty in speaking. The patient woke up with the symptom of aura before arriving but felt when he went to the bed last night. He had the history of proximal artery fibrillation, but is not at a high end with the medical therapy. Temperature is 98.6. Blood pressure is 130/70 and the pulse is 110 per minute and irregular. Physical examination shows a right-sided hemiplegia and hemisensory cirrhosis and aphexia. Despite appropriate treatment, the patient's symptoms failed to improve over the next week, which of the following process is most likely occurred in affected brain region. In these MCQs, we have two level of necrosis. Which type of necrosis will happen in the central nervous system? In this, if you know, in brain there's a many type of a high number of enzymes are present to enter CNS. In central nervous system, they will liquefactive necrosis will be happen and it is due to hydrolytic enzymes. And answer is a hydrolytic enzyme induced tissue digestion. If we talk about the different types of the necrosis, and either liquefactive necrosis, coagulative necrosis, Caseous necrosis, fake necrosis, and Fibrinoid necrosis. If any ischemic attack, ischemic injury, if happened outside the central nervous system, then if most probably coagulative necrosis. If any ischemic attack and infection is happening in the central nervous system, then it will be liquefactive necrosis. But the fibrinoid necrosis is mostly due to the hypertension and vascular damage of the vessels that lead to fibrinamium complexes and it having that eosinophilic layer or proteinous material in the vessel walls. In fact, necrosis could be due to acute pancreatitis and a trauma due to trauma of the adipose tissues and subcutaneous layers. And caseous necrosis due to mycobacterial infections and a fungal infection that make appearance like a cheese disease like material composed of cell fragments and amorphous proteinous structures. So if any inflammation, any ischemic attack is happening in the CNS, then it will be liquefactive necrosis. Outside the CNS, it will be coagulative necrosis. Our next question is, a 46-year-old man present to your office with a slowly growing neck mass. The mass is a strawny hard. On palpation and seen to the fixed, and after initial evaluation, combination of chemotherapy is prescribed to the patient. Several weeks later, the mass significantly decreased in the size, and biopsy demonstrate many shrinking eosinophil cells within the tumor, which is a foreign substance that released from the mitochondria most likely triggered to observe several changes. Actually, in this mechanism, the cell size is increased after sometimes cell size is getting shrunken or decreases. Due to which substance and it's a substance that is released from the mitochondria. So from the mitochondria, you all know regarding that type of mechanism, apoptosis. In apoptosis, a substance called cytochrome C is released from the mitochondria. And cytochrome C is a mitochondrial enzyme that activates the TAT species and indirectly bring about cell death through intrinsic pathway of apoptosis. And UGOR is known apoptosis is the means of carefully regulated cell death in which the cell activates enzyme to degrade its own nuclear DNA and proteins. Simply, it is a natural cell death phenomena. If you guys move to the next question, the next question is, a 65-year-old man come to emergency department due to acute onset, severe right flank pain, nausea and vomiting for the past hours. His medical conditions include prostate cancer and membranous nephropathy. Blood pressure is 148/60 and the pulse is 95 per minute. On physical examination, the patient appeared to be moderate distress due to the pain and diaphoretic. Okay? These are right costovertebral anger tenderness, urinary lytical hematuria, and in contrast, enhanced scan reveals the wedge-shaped perfusion defect in the right kidney. The affected renal tissue is most likely to develop which of the following histological changes from the next advertise. Actually, this all phenomena is speaking about the ischemic attack. Okay? And already we discussed about if there any ischemia or ischemic attack or infections happening in the CNS, if we call the liquefactive necrosis, but now they are asking about the kidney. If any ischemic attack is happening outside the central nervous system, like kidney, lungs, or in liver anywhere, then it will be coagulative necrosis. Answer will be coagulative necrosis because in MCQ he's asking the condition the patient is describing now, okay, if he will be persist with this condition in upcoming days and several next days, what things will be well in right kidney? It will be coagulative necrosis due to ischemic attack. Okay, understand? Yes, if you guys move to our next question, and it is about a 24-year-old man evaluated for recurrent episodes of abdominal pain and a bloody diarrhea. The patient has also low-grade fevers and fatigue. Physical examination reveals left lower quadrant tenderness. It is scan of abdomen short technique of distal colon and rectum. During one of the laboratory tests, the patient anticoagulated blood is placed in the upright thin glass tube and left undisturbed. His red blood cells from check and set to the bottom at a fast rate of 50 mm per hour. Serum levels of each of the following substances most closely associated with these observed findings. First, we have to diagnose the case. Okay? He having the abdominal pain, bloody diarrhea, and secondly, having a thickening of distal colon with the rectum. If you guys know, the most probably the case of the ulcerative colitis because it's involving the rectum with the bloody diarrhea and abdominal pain. Okay? And this patient who had recurrent abdominal pain and bloody diarrhea with the CT evidence of bowel wall thickening in the distal colon and rectum likely had ulcerative colitis. In chronic inflammatory conditions are characterized by the persistent stimulation of neutrophils and the macrophages, leading to the long-term elevation of circulating pro-inflammatory cytokines, such as interleukin-1, interleukin-6, and tumor necrosis factor alpha interferon gamma. The liver responds to these circulating cytokines, particularly interleukin-6, by generating acute fat reactants, protein that modulates and inflame the inflammatory response and play some important roles in innate immunity. For testing about the ESR erythrocyte segmentations, the one factor that is involved in all the things is interleukin-6. Okay? Because it's the one ulcerative colitis. It's a chronic inflammation. And chronic inflammation mostly contain it mostly circulate elevation of pro-inflammatory cytokines. Pro-inflammatory cytokines. And always remember that the pro-inflammatory cytokines involve interleukin-6, interleukin-1, tumor necrosis, factor alpha, and second interferon gamma. Okay? So it answers interleukin-6 because it is a chronic inflammatory condition. And guys, now we have to move our next question. A 64-year-old man presents with diarrhea, abdominal pain, nausea, vomiting, and anorexia from the 3 weeks after starting radiation therapy for prostate cancer. Okay? Physical examination shows abdominal tenderness. Sigmoidoscopy reveals hyperemia, edema, erosions, or dilation of intestine and mucosa. Stool in the serum chemistry is a normal. Radiation enteritis is suspected, which is found with the most likely the primary mechanism responsible for these patient intestinal changes. What intestinal changes? Diarrhea, abdominal pain, nausea, vomiting, and anorexia. This patient were the signs of acute radiation enteritis. Both you were already going without radiation therapy, and these acute radiation enteritis include the abdominal pain, diarrhea, inflammation, and the inundation of intestine and mucosa. And 3 weeks after starting the radiotherapy for the prostate cancer, therapeutic ionizing radiations are commonly used to treat or palliate many types of cancer and causes all cell limits through two primary mechanisms. First, DNA double-stranded breakage, in which the breakage of both strand is required and single-stranded breaks can be repaired by the polymerases. And second is generation of reactive oxygen species, that is unstable molecules formed by the ionization of water oxygen-free radicals that can cause cellular and DNA damage. And in these, all the things, radiation-induced DNA damage, impaired mitosis, and initiate the apoptosis of susceptible cells, including the intestinal crypt stem cells and other highly proliferative cells like cancer cells and hematology and necrosis. And these severe damage also induces an immune response factor that will increase expression of pro-inflammatory cytokines like interleukin-1, 6, tumor necrosis factor alpha, and migration of leukocyte-like neutrophils to the affected tissues. And these processes that produce additional reactive oxygen species and contribute to radiation-induced tissue damage. In the gastrointestinal tracts, these changes result in progressive inflammation, edema, and mucosal denudation that can decrease their absorptive area, and abdominal pain and diarrhea typically manifest several weeks after the radiotherapy is started. In some cases, the effects of radiation exposure can be delayed until years after radiation exposure and present as a complication of intestinal fibrosis, extravasation, and bowel obstruction. According to that, already I told you, in these all the things, there are two steps, okay? There are two steps to treat or palliate many types of cancer. First is DNA double-strand breakage. DNA double-strand breakage, and third, generation of reactive oxygen species. And already there is an option of generation of reactive oxygen species, because these become and these product of unstable molecules that are formed by the ionization of water and oxygen-free radical that cause that cellular and DNA damage. And these oxygen species can cause that intentional changes. Okay, hope this should be understandable. Again, saying one thing, the radiation therapy kill the cells by the two things, was it DNA breakage, and third, genetic of reactive oxygen species. And this mechanism can cause all these diarrhea, abdominal pain, nausea, vomiting, and anorexia after the radiation therapy. Now we are going to the next question. A 74-year-old woman. 74-year-old woman comes to emergency department due to 2 days of left leg pain and numbness. She had a history of atrial fibrillation and hypertension. Her left lower limb is pale and cortical pushing below the knee. Arterial fibrillation shows an occluding thrombus, and left femoral embolectomy is performed. Both procedure draws slightly various and posterior tibial pulses become palpable. Several hours later, the patient began to experience weird left calf pain. On repeat examination, the left calf is swollen, dense and tender, and the pain worsened with the dorsiflexion of the foot. The disturbance is absent. The physician suspect injury of the reperfused muscle is apart due to overproduction of reactive oxygen species. Which of the following enzyme is most likely help to neutralize a toxic molecule? Guys, I want to share one more quick with you whenever you are doing any clinical-based question like this. Try to read last two lines first. Okay? Like the first line in, last line in which of the following enzyme is most likely to help neutralize this toxic molecule. The last statement you can get, but you have to answer. You have to answer any enzyme which neutralizes a toxic molecule. Next, we have to read Secular, the physician suspect entry of the reperfused muscles in the pouch due to overproduction of reactive oxygen species. In last two statements, we got our question. You don't have to read all the statement. If the questions are time-based, okay, the question is, which enzyme is going to neutralize the toxic substance and toxic substances, the active oxygen species? As you guys all know, in mitochondria, there's one enzyme superoxide dismutase that neutralizes reactive oxygen species. I also having one diagram with me. This one, like if any radiations, toxin, reperfusion happening, and they will be production of reactive oxygen species. This superoxide is converted into hydrogen peroxides by the help of superoxide dismutase, and this will neutralize into water by the help of catalase or glutathione peroxidase. If these become again dihydroxyl radicals, then it will be due lipid peroxidation, protein damage, and DNA breaks. But now, for the neutralization, we have one enzyme in mitochondria. This is superoxide dismutase, okay? And this all about our today's MCQ practice session. For more practice, you guys can go to YouTube of Dr. DC Online. When you guys search on this, you can click on the pulse session. There's a many MCQs are there. By the name of USMLE Practice Pulse.